So I'm actually not talking too much about my research, but just giving you a little bit of information about bone health that I hope will be helpful to you. Let's see. I have two clickers. Let's see which one works. Oh, that one. Okay. So this is the problem that FSHD, as you know, leads to decreased muscle mass, and decreased muscle mass and decreased strain on the bones leads to decreased bone density. With increased muscle weakness comes an increased falls and increased risk then of fractures. Fractures can cause pain, deformity, depression, disability, decline in quality of life. Half of all people, for example, who break a hip never walk again. So how can we prevent this? What is the solution? FSHD Global commissioned a bone health study. Oops, is this the right? Yes, sorry. Just making sure I'm on the right talk here. Bone health study, which, as Natalie mentioned, is a collaboration between myself in Baltimore and Alistair Corbett here in Sydney. So together, we're enrolling 100 people with FSHD. 50 Baltimoreans, we do actually call ourselves that, and 50 Aussies. And we're looking at fracture history, bone density by DEXA, bone biomarkers, and muscle strength and function. And several of you in the room, I understand, have participated in this study. So I want to thank you that, I hope that you got something out of it, all, learning about your own health, but you're also really helping contribute to the health of those with FSHD in general. So what is the function of bone? It's structural. It protects some organs from injury. It's an attachment site for the tendons of muscles, allowing us to move. It also has major metabolic functions. It's a reservoir for calcium, phosphate, and other minerals. And it's the primary site for production of red and white blood cells. The components of bone include an outer cortical layer. It's dense and compact, and it resistant to bending, and an inner trabecular area that's less dense. It's that honeycomb appearance. It's more elastic. It increases in density during puberty and decreases in density with age. Bone undergoes a constant remodeling. It's constantly being renewed. Bone is being removed and replaced, and this process of formation and resorption is called bone remodeling. Osteoblasts are the cells that are responsible for bone formation. They lay down new bone, and osteoclasts are responsible for bone resorption, and they resorb the old and damaged bones. So bone remodeling varies with age. In childhood, bone formation outpaces resorption. As young adults, formation is coupled with resorption. And then with aging, resorption exceeds bone formation, and this leads to the loss of bone mass. So there's several determinants of bone mass. I've already mentioned muscle and muscle function. There's a genetic predisposition. There are various endocrine, hormonal contributors, and various lifestyle contributors, nutrition and exercise, and I'm going to hit on these. So in terms of hormones, estrogen in women is protective on the bone. It inhibits the osteoclast, so there's less resorption. With menopause, there's a decline in estrogen, which leads to accelerated bone loss in postmenopausal women. For men, testosterone inhibits bone resorption and maintains bone mass, so lower levels are associated with accelerated bone turnover and increased fracture risk. I think there might have been something there, but it's not there anymore. there are various different hormones in addition to estrogen and testosterone. So the parathyroid hormones, parathyroids are little glands on the sides of the thyroid, and they're principal regulators of calcium in extracellular fluids. They increase calcium concentration and stimulate bone formation. And calcitonin is produced by the thyroid gland itself. It stimulates bone formation and is released when calcium is high. So the FDA, that's our regulatory agency for drugs, has approved the treatment of osteoporosis with both parathyroid hormone and calcitonin nasal spray. Now, in terms of nutrition, vitamin D is critical. It's needed for calcium absorption from the gut. So you're probably all familiar with rickets or osteomalacia, which is a severe deficiency of vitamin D and softening of the bones. One can measure the levels of vitamin D by checking specifically 25-hydroxyvitamin D3, which is what is the active form necessary to absorb from gut. And the sources of vitamin D include sun and diet. So sun is important. Skin exposure to the ultraviolet B radiation from the sun provides the vitamin D, and it requires direct exposure to the sun without use of sunblock. Food sources include fatty fish such as salmon, tuna, herring, eggs, fortified products such as soy milk, almond milk, rice milk, orange juice, cereal, and various dietary supplements. Calcium is required for the maintenance of bone. One's needs for that change throughout the life cycle. Peak nutritional needs are during adolescence and during periods of rapid growth. Sources of calcium, of course, include milk products, cheese, and yogurt, but also many non-dairy food sources, such as I've shown here. Tums, calcium carbonate, is also an excellent source of calcium. So the optimal daily calcium intake, as I mentioned, does vary across the years, but one could say approximately 1,000 milligrams per day. It's harder to say exactly what the optimal dose of vitamin D level is, as it really does depend on how much sun one gets. So there are other things that one can do in terms of bone density, such as lifestyle. Physical activity is extremely important. Exercise, as we've just been hearing, is good for muscle, also extremely important for bone. Weight-bearing activities and mechanical stress promote osteoblast bone formation and inhibit osteoclast bone resorption. Prolonged bed rest and immobilization inhibit osteoblast bone formation and accelerate osteoclast bone resorption. Other risk factors for fracture include age, greater than 65 for both men and women. Postmenopausal women see a sharp decline in estrogen and increased risk of fractures. Ethnicity also plays a role in fractures. Being Caucasian and Asian are risk factors. Family history, previous history of fracture, very low body weight, smoking, alcohol in excess or greater than 3 a day. I'm not sure that's actually in excess, but certain drugs such as corticosteroids, and several chronic disorders including rheumatoid arthritis, diabetes, untreated hyperthyroidism, hyperparathyroidism, chronic malnutrition, malabsorption, chronic liver disease, etc. And then the question is whether FSHD is also a risk factor for fractures. So how do we study this? The best predictor for fracture is the bone mineral density. And we look at this through DEXA, and that's one of my patients with FSHD getting a DEXA scan. This is the imaging technique of choice. It's easy. It takes about a half an hour. It's minimal radiation, about 1/10 of a chest X-ray, and follow-up studies are required to follow the change in bone density, and these should be done at the same facility due to some differences in techniques. So when you do a DEXA scan, you learn whether you have normal bone density, whether you have osteopenia or osteoporosis, and those are different severities of loss of bone density. The values of the bone mineral density are in the form of what are called T or Z scores. The T score compares the patient's bone mineral density to the average of young adults at the time of peak bone mass, and the Z score compares the bone mineral density to persons of the same age. The lower the score, the greater the risk of fracture. So osteoporosis, the bone is fragile and prone to fracture, as shown in the example there, where the trabecular bone, the spongy part of the bone, the spaces have gotten much larger and the bone spicules much thinner. And this can lead, for example, as shown below, in the vertebrae of what's called wedging or compression fractures. So osteopenia is defined by the World Health Organization as a bone mineral density between -1 and -2.5 standard deviation in T scores, and osteoporosis, a bone mineral density of a -2.5 standard deviations below that of young healthy adults. So the more negative number, the worse the bone mineral density. So you can actually calculate your risk of fracture using an online tool provided by the World Health Organization, where you can enter your country, because there are differences there, and your age, gender, weight, height, and some of the risk factors that I've already mentioned, and then also entering in your T-score. Here it's calling for your T-score at the femoral neck, at the hip. And then it tells you what your 10-year probability of a fracture is. So how can we reduce the risk of fractures? Well, lifestyle, exercise, smoking, alcohol, we have some control over. Nutrition, calcium, vitamin D, we have some control over. And then there are really good medications to increase bone density. Some of these drugs are called bisphosphonates. They are available orally and also intravenously. So there are some, bisphosphonates reduce bone resorption by decreasing the activity of the osteoclast. There are some side effects to these drugs. Sometimes, particularly the IV forms, there are flu-like symptoms, especially with the first infusion. There is a risk of having one's calcium level drop too low, and there is a risk of osteonecrosis of the jaw. That's actually very rare, however. How long to treat with bisphosphonates is not always clear. After 5 years of treatment, there is probably no longer a benefit. Now, if one is unresponsive or intolerant to bisphosphonates, there are other excellent drugs to increase bone density. So there are anti-resorptive agents, including Prolia. This is an antibody that binds to the regulator of osteoclast to inhibit bone resorption and stimulate bone. There are other drugs which stimulate bone formation, such as the parathyroid hormone Forteo. So we're just completing our enrollment of the 100 FSHD subjects in the bone health study in Baltimore. We've found that about 48% of them had normal bone density, 36% were osteopenic, and 16% had osteoporosis. What was very interesting, and we're going to do more correlation analysis, is that the bone density was linked to the allele size, to the severity. So the more severe FSH had less bone density, and to strength in the hip flexors, the quads, and the hamstrings. So recommendations that we can make right now are, regardless of your age and strength, you should check your vitamin D3 level and correct it if deficient. You should get a DEXA scan if you're 65 years or older, if you're no longer walking, or if you're falling. You should check your fracture risk, and you should make some lifestyle or medication changes with the assistance of your physician if possible. And I hope that next year, if I come back next year, that we'll have some specific FSHD recommendations from this study that is funded by FSHD Global. So I'd like to thank the people that work with me, particularly Carla Grossman, who helped with these slides. That's a picture of where I see patients, and we have one person in the audience who came to visit me there. And thanks to FSHD Global.